So some of what I'm going to cover has already been covered, so I'm not going to dwell on that being the last presenter today, so I'm not going to dwell too much on it. But I just wanted to look here at the principles that guide the NHS, just to remind ourselves there. And we've been talking about person-centred care. And look at that fourth bullet point there. So even with the NHS constitution, it's there. So it's there for us from the word go, from the guidance that we hope to work towards, and the constitutions we hope to apply. So whose wound is it? You know, what about rights and responsibilities here? So you can see there on the left-hand side what the rights are. They're written into law. They can be defended in a court of law. But what does that mean to patients and what does that mean to clinicians? One example for the patients is about accessibility to a GP, and for us is to have a good environment in which we can work. So the rights are there for us. Responsibilities, we haven't got that legal backing to it there, as you can see. These are more obligations. There's a couple of examples there for you about patient public responsibilities and clinicians. The course of treatment will come back to as we go through the presentations. And an example, I thought I'd give a completely different one, is we have to be honest when we're applying for jobs. Because I have sometimes seen some CVs and I've thought, really? As Mel and Karen said, in Wales, and I have to say they are absolutely inspirational team, our lymphedema team to work with, they are superb. We're very, very lucky there. But Mel said about talking the right language, and our government in Wales, we talk about prudent healthcare. And in prudent healthcare, we talk about people being equal partners. So we've got this co-production already going on. And look at that second one there, care for those with the greatest health need first, which is what Mel was alluding to. So in Wales, we've got this background of prudent healthcare, which we try and follow through all our nursing care practice, wound care or not. So Ellie asked me to say, well, who's in charge of the wound? And I would say to you, if I was doing this presentation pre-COVID, I think I would come up with a very different answer. But it's changed. It's changed what we do. It's changed how we work. So pre-COVID, who would be in charge of the wound? And I probably would have said, as a nurse and doctors, physios, OTs, we were. Post-COVID, are we still? I'm not so sure. Because that third bullet point there is a reality now, isn't it? It's a reality. We've heard lots of issues today about how people cannot manage it, under-resourced, we're not meeting targets. And we have got this reduced access to services. It's very different nowadays post-COVID. This has been discussed, so I'm not going to discuss it in any great detail there. Those points have already been made, but I've just put it back up there for you. And I'll talk about the human document later on. Here, perhaps there's a different slant on it, talking about the critical attributes that you need, both from a nursing one and the behaviours that surround that. So we talk about person-centred care, but we've got to be able to put it into context and put it into practice, haven't we? And you can see that the attributes that we need there to do that. And I think we've heard many times today people talking and demonstrating those attributes in the care they've given. About respect, haven't we? Teaching, education, all of that we need. We can't just say we're giving person-centred care without looking at these attributes and behaviours that we need to demonstrate as part of that. So what are the client responsibilities out when we come down to wound care? Follow the plan of care, and I was a bit wary about that at first. It was smacking a bit of do what I say. And I thought, hang on, that's perhaps not what it's all about, is it? But the second bullet point, I think, negates that, doesn't it? That if people are not happy or not able, that they can ask us and they can discuss it, and that's when we can negotiate. And we've heard marvellous examples of that today from all the clinicians here. We've heard about optimising skin, diet, etc. and investigations. So we've covered that, I think, today. But there are responsibilities for us both. So what are our rights and responsibilities in relation to wound care? And Jamel has just made the point about education, training and skills. She's made the point that you don't stop 9 to 5, do we? We care for patients constantly. We've talked about the red flags today, things that alarm us and get our action a lot quicker. But you can see those other bullet points there. We've got lots of rights and responsibilities there. And they're all, I think, focusing on delivering that person-centred care. But we have to take all these on board. and make sure that we are looking at these on a regular basis and reflecting on our practice to see, are we making these changes? Are we working in that kind of environment with those kind of attitudes and beliefs? So if we're talking about sharing the care with the patient or passing the care over to the patient, whose rights, whose responsibility, the one thing we learned, and a lot of this is very about our personal experience in our clinics in South Wales, the first thing we realised is when COVID hit, our district nurses discharged our patients with wounds. Bag of dressings, off you go. We were waiting for that sudden rush of COVID patients onto our books. Didn't happen, but we didn't know that. And if you remember as well, we were all really, really frightened, really anxious. So what we didn't do was prepare our patients. So if people are going to look after their own wounds, are going to self-care, are going to take the responsibility, we have a duty to prepare them for this. And a lot of them didn't know what their underlying condition was. I've got an ulcer. What kind of ulcer? Not a clue. They thought the ulcer was a diagnosis, which we know it's not. We're all very good now at hand washing. Yeah, I think that's one thing COVID has taught us, and we've seen people so good at washing their hands now. Yeah, it's excellent, isn't it? They didn't know how to get rid of the dressings, the equipment. They were just putting them into the clinical waste. They didn't know what to do with them. They didn't know how to get more dressings because people they normally would have contacted no longer were there. So there were big problems in the fact that we didn't prepare our patients properly. But people soon come to your help, don't they? They soon come and help you with these things. I won't play it now, but if you go to YouTube here, this is also, you can locate it from the National Wound Care Strategies homepage as well. Videos to demonstrate to patients how to change and redress a wound. And if you look at this evening, it's not as easy as you think. We're so used to doing this. It's second nature to us. But when you're a patient, do you put your gloves on first or your apron? How often do you wash your hands during a dressing change? We do it automatically. But for patients, it's a whole new skill set to learn. But we have these lots and lots of resources on the TVS website again, lots and lots of resources now. And with resources that are written, but we've also wrote resources that if you can't read, you can use them. So we've got lots of nice resources. So have a look at this on YouTube tonight. Oops, there we are. But we have to be aware of this, don't we? Yeah, a lot of people and a lot of people that we work with digitally aren't that savvy, as Chris knows. Am I right, Chris? Yeah, okay. So have a look at those figures there. People are not always able to use the electronic resources that are available to them. So be aware that perhaps that isn't always the answer. People think it's a move forward, telemedicine, it's fine, but it isn't always the case. So always be aware that there are people who are digitally excluded, especially in Wales we have that problem as well. But as long as we've also got digital exclusion, we've also got poor health literacy, haven't we? And we've heard today about leaflets, about sharing communication, educating patients, but we have patients that can't read or write. So we've got to be aware that what we're producing for patients, if they're going to take over their care or manage their care, it's got to be in a language that they can understand and a language that they can deal with. Because look at those skills you need on e-health literacy. And I'm sure I haven't got half of those skills, have I, Chris?
Yeah, no problem.
Thank you. Okay. And that bottom one as well, isn't it? Protecting privacy on social media. That's what people get really quite frightened about that. So back off from those situations there. And how many of us have been in clinic when the patients come in with the printout off the internet, you know, wanting the stem cells? Yeah? Yeah, we don't have them in South Wales. Yeah, so again, it's not always easy to negotiate these things if you're not digitally that savvy. Yeah, there's your reference. But there is some positives out there, and I found this nice paper by Jeanette Milne, TVing up in the northeast. And what Jeanette had done is she said, right, we are under-resourced, we cannot manage. But we've got to deal with this somehow. So she turned to digital platforms to help her. And you can see there what she got through this clinical platform that she took on board in her health organisation there. And you see what people can do. She could do video consultations, there were admin tools there, she got reports, she could pull audits, she could pull data from there, she had the pathways that could be adapted to the patient's diagnosis. So she had all that information that we've talked about in different sessions today, but this all went through her digital platform there. and people could upload photographs, wound assessments. It was all there within this digital platform. And she integrated this into a very rural community. And it used to take, she talks in the article about having to take 3 hours to get to the patient, assess them and then get back. And she said no longer could they do that. This is in the northeast, it just was not possible. So by implementing this digital proaction, look at that there, she reduced the times to 30 minutes. Patients didn't have to wait as long. The staff were a lot more happier because they knew that when their referrals went through to this virtual platform, they would be dealt with in a timely fashion. We've heard about that today, especially from Jamel, about how you need to act when you need to act and not hang around. And patients were treated quicker. So this is a nice example that you might want to have a look at if you're thinking of going digital, where there seems to be success there. Mind you, Jeanette said there were problems, and we find this all the time in Wales. I don't know what you do, that you have this marvellous IT idea and then the NHS firewalls block it. Yeah, and you can't communicate with each other. We're just going into electronic patient records in Wales, and we are having big problems. In parts of rural Wales, the connection to the internet is actually, it's just not there. So it's just not working when we're trying to access information from each other in different health organisations. So there are problems there. The other thing that I thought was quite interesting, she was saying that because the patient's in their home, you think they're in a safe environment. But if they're showing you wounds, and sometimes we know ourselves these wounds are in quite intimate places, we've seen groins this afternoon, you know, are they in a place where there's other people there who they actually want them to see them showing the groins to people? And we always presume because they're at home it's safe, and it isn't always that safe, and they picked up on that pretty early on when they were implementing this digital platform. So these now are just my own personal reflections on self-care and sharing care. I think there are disadvantages and advantages for the individual. If they're used to seeing us 3 times a week to put the bandages on, and they're no longer seeing us 3 times a week, it alters our relationship with them. And we've heard lots and lots about building that therapeutic relationship. Well, that is quite vulnerable in this situation. If you're suddenly getting your family to redress your wounds, and we have lots of young men who have their pilonidal sinus wounds dressed by their mothers, that's not perhaps a relationship that those 2 people want. So it's not just a case of can the carer do it, and if they can, well, that's fine. That's not always the case, is it? Sometimes patients don't want the responsibility of doing their own wounds. It's too much. You know, for us, sometimes you're there and you're thinking, what do I do? How must someone with no medical or nursing background feel about that? Quite frightening. And along with that comes the anxiety. And again, Mel and Karen discussed that earlier, didn't they? And we found that people were healing slower when they were managing their wounds. But this is not any a formal investigation of the data. This is a general feeling amongst our team. And we found that things tended to go wrong because there wasn't that supervision. But there were advantages because the patient then owned the wound. It was their responsibility. So like I talked about yesterday in the workshop about patients that are just coming into hospital, going to bed and nurse, you look after me. That changed, that mindset changed. Responsibility went over to the patients, and that was a big shift for us, They learned new skill sets, you know. They came pretty good at compression, pretty good at doing dressing changes. New skill sets is a bonus and advantage, which again Chris has taught me today. I now know what 16.9 is on the slides, that's good. Yeah. The flexibility, not waiting for the district nurse to come there or having to try and get an appointment with a practice nurse. We know that's really tricky nowadays. They were able to carry on with their day-to-day activities. They didn't have to then put everything on hold because of that particular wound. And they became very knowledgeable. And I like knowledgeable patients. I like patients who know about their wounds, who can recognise subtle changes before we can. That's really helpful to have someone else on the team who's an expert in that particular wound care. I think it's a marvellous advantage. Some people don't. Some people find it a bit intimidating when the patient knows more. But I think it's marvellous. Advantages for us? Well, we had to learn new skill sets. We had to learn how to assess patients as to whether they were suitable for self-care and managing their own wounds, because not everybody is. We had to get used to shared care. We did it all before. It was always us. We had to improve our education skills. To teach someone without any nursing or medical background how to manage things, it's different than teaching a colleague to do it. So we had to improve our education and our communication skills to get our messages across. We had to look at these red flags, and we've heard about these red flags, sepsis, etc. But for us, we also looked at other red flags, not just the ones that we shared with the patients. So were the patients having more analgesia prescribed than they had before? So was the pain there, but they weren't telling us? But the GPs were prescribing more? We needed to keep a close eye on that. Were they ordering more dressings? Does that mean the exudate wasn't being managed correctly? Were they being changed more often? So we had to perhaps keep an eye on that as well. Were they going more often to the surgery? Is that a cry for help that they weren't able to verbalise to us necessarily? And again, were they having prescriptions for other things, such as antidepressants that they weren't on before? Was this responsibility and anxiety just far too much for them at this moment in time in their life? So there's your ordinary red flags, but we had to sort of think a bit different and add new red flags in for us as clinicians. Disadvantages, we lost control, and no one likes being out of control. Well, I don't personally. You all might be fine with that, but I'm not too good on that. I like to be in control of things. I find it quite vulnerable when I'm not, but I no longer was in control. The patient was in control. And then we did have these more complex problems. So that is quite anxious as well, a lack of control, and then these more complex situations occurring. I don't know about yourselves, when anyone tried telephone triaging, and you get the patient to describe the wound to you, the individual, yeah, and then they show you a photo of it, and you're thinking, were they looking at the same thing when they were describing that to me? Do you ever have that? Do you have it with your colleagues as well? They'll refer someone to you, you'll read the referral form, then you see the wound and you're thinking, these two don't match. So there were definite limitations in that, especially again, not having a mobile phone, not being able to use the camera, especially if it's a wound in a difficult area to photograph. So there were problems. It wasn't just the answer was telemedicine. That wasn't all the answers that we needed there. It de-skilled us. If I'm compression bandaging 4 times a day, 5 days a week, as Jamel was saying, you get that experience, you're pretty good at it, aren't you? But then if you don't bandage at all for 3 months, you're de-skilled. And we found ourselves being de-skilled because we weren't practicing those skills. And also, we found that what we were doing sometimes, we were having to discuss with the individuals to try and come up with the best regime for them that they could manage themselves. And sometimes that was suboptimal. It wouldn't be exactly what we wanted if we were doing it ourselves. But we had to let go of that and have to negotiate that. But at times that was quite difficult to do because we wanted to keep things as tight as we could, when in fact in those situations we had to let go of some of that and have some suboptimal therapeutic regimes, which wasn't easy. An article by Anne-Marie Brown talked about empowerment. And this is what we're doing here, isn't it? We're empowering patients. And with empowerment, there's 3 sort of sides to it, really. You can sit and have the conversation with the patient, and you can say, this is a problem. You can ask them what their issues are, as our lymphedema colleagues were saying, and we can discuss the ways forward. And then the individual might say to you, fine, thank you very much, know what's what. I'm quite happy to take it all on board. I will do that, no problem. Then they might have that negotiation with you and say, okay, I'll do it at the weekend, but are you there in the week? Yeah, when you've got that shared care. Or they might say, at this moment in time, that's just too much for me to take on board. So can you carry on, and then let's work towards a further negotiation. And it's not linear. Quite often you go back and forward, depending what's going on in that individual's life at that period in time. So you have to be aware of that. And what Anne-Marie says in her article, you don't need to just have the ability to do it. You need to have the confidence in your own ability. So it's not just, yes, can I watch you bandage? Yes, you can bandage. No, it's about having confidence. And if you haven't got that confidence, it's very difficult to accept that you can carry on taking that further forward. And she talks about people having internal and external locus of control. So with an internal locus of control, you believe things are your responsibility. And the people with that, she found, managed the self-care better than those who felt it was someone else's responsibility. And that's why those rights and responsibilities need to be revisited. I just want to share with you before I finish, there's some assessment tools. The first one there, and again, like Jamel, you're welcome to the slides. That's on the National Wound Care Strategy, and it's a real nice contract. that talks about assessing a person. Are they able to manage self-care? But when you've assessed, it also then says you have that conversation, do you want to? You can do it, but is that what you want to do? So it's about having those conversations, and it's a really nice contract to have a look at, to perhaps use when you're assessing patients and working out where that care goes with the patient, with the healthcare professional, or a joint venture there. Also there's a nice assessment tool that was produced by Zena Moore, as you can see in Wounds International, and they've got a shared wound care discussion guide. And it's a nice flow chart to take you through the assessment with the patient and moving forward. So it's a nice decision-making tree that you can look at to see if that will help you in those discussions with individuals about person-centred care. The other two I came across here were about the STOW checklist. And this was a nice piece of research done. It was a very nice piece of research that was done by CAP. And I noticed CAP was in an earlier presentation this morning as well. And they again have got this checklist for people to say, is it the right thing to do, and help you making that decision there. And what happens here, the healthcare professional will watch the person redressing the wounds, taking the wounds down, doing the cleansing, looking after the skin, redressing, and they look at that, and then they came across them with criteria, and those criteria were then used in the assessment to help decide whether the individual was at that right point in time for taking on the care. And that's really worth looking at, that checklist there, and we've put the link for you in the presentation. So finally, I think you've probably got enough to read tonight. I certainly have. I know that when I get in. But this is a lovely document from UMA, and I always find the European Wound Management Association documents are excellent reads. Really good reads. They are nice, objective pieces of work that have really good content, very helpful content. And this one on person-centred care I found was really, really super. So if you want to know more about this subject, I really can recommend this as some bedtime reading. So in my conclusion, who's in charge of my wound, Ellie asked. Well, I think as healthcare professionals, we stole it for a while, but we're giving it back now. Thank you.